morning, everyone. Thank you for the opportunity to be here. Just open the presentation in a second. Okay, excellent. So first of all, I'd like to show you how coronary CT angiography got a more and more prominent role in the society guidelines in the last decade, starting with the UK in 2016, following in 2019 with the European Society, and following up in 2021 when the American societies followed suit, and they all pushed coronary CT angiography into the first line of diagnostic tests in the diagnosis of coronary CT angiography. And we can safely say that there's a growing need for CCTA examinations worldwide. We can already see the rising number of CCTA examinations. In the UK, this red line, you can see that the numbers are growing, and the same can be said in the US. But we also have to improve the access to challenging patients as well. Patients who were previously said to have relative contraindications for coronary CT angiography, for example, a high heart rate, in the case of arrhythmia or even stents. In order to have a good image quality of these patients, your scanner has to have a couple key features. For example, high temporal resolution, high spatial resolution, and the wide coverage. RNet-NG introduced Cardiograph in 2017, which was the first dedicated cardiovascular scanner on the market. And one of the first scanners were installed at my hospital in Heart and Vascular Center in Semmelweis University in December 2017. And this scanner is a one-beat whole heart coverage scanner. It has a 0.24 second rotation time, which is quite fast. And it is also applicable for structural interventional planning and vascular scans, for example, carotid scans, aortic scans. And nevertheless, it has a small footprint of only 15 square meters. What are the advantages of having a dedicated cardiac CT system in your hospital? There are a couple of papers in the literature underscoring its importance. First, from the Leipzig group, they compared a dedicated cardiovascular scanner with a standard multi-detector CT in 400 patients, and they found that with the dedicated scanner, there was a better overall subjective image quality with higher signal-to-noise and contrast-to-noise ratios compared to a standard multi-detector CT. Our research group in Semmelweis also did a comparison with the Cardiograph, and we compared it to a 256 slice scanner in 80 patients matched for scanning parameters, and we found a better interpretability on a per patient, per coronary, and per segment basis in heart ranges over the usual target heart rate of 60 beats per minute. Nevertheless, the effective dose was significantly lower in the dedicated scanner. And this led to another retrospective analysis in our research group, which was associated with the COVID pandemic. Because before the COVID, we used oral premedication and IV premedication as well, but due to the COVID, we wanted to get rid of the long waiting for the patients in the waiting areas, so we switched to only IV beta blockers. And we did a retrospective analysis comparing 1 year with each protocol. And we found that on the multi-detector CT, we had a worse image quality with only IV medication, while on the dedicated scanner, the image quality was not significant. With the two protocols, which led to actually our protocol right now that we got rid of the oral medication totally ever since. The second generation of this scanner is called the Spotlight and the Spotlight Duo, which was introduced in the last fall. The first dedicated cardiovascular and thoracic CT scanner of the market, and with two new extended field of view options for full thoracic coverage, it has an extended application. And the scanner setup options is a Spotlight with a 25 centimeter field of view, a Spotlight with extended field of view option of 45 centimeters, and the Spotlight Duo setup is with up to 45 centimeters field of view with high resolution detectors. So let's check under the hood. the technical parameters of the scanner. This scanner has a unique stereo CT technology with two tubes in the Z-axis, which allows us to have an increased coverage of the heart. Its narrow detector reduces the cost, and the small bore is for dose efficiency. One rotation covers 140 millimeters of the thorax, which allows us a one-beat whole heart scanning without step artifacts. It has 280 detector rows, and the dynamic focal spot is for the high resolution mode. So the temporal resolution is 120 milliseconds, which is a very good temporal resolution. The spatial resolution is 1/4 of a centimeter, and it has 80 to 140 kV scanning modes. And again, it has a small footprint of 15 square millimeters. So how these extended field of view options look like? We have a high resolution detector setup covering the heart. And with the extended field of view, there is high sensitivity detectors. There are high sensitivity detectors outside the heart, which allows us high resolution in the central area and a lower resolution outside of the 215 millimeters field of view. But this resolution allows us to interpret lung changes and vascular anomalies or vascular changes with high degree of confidence. And the Spotlight Duo setup has a 450 millimeter total field of view with high resolution detectors on each side and high sensitivity detectors on the other side. And the whole thorax can be assessed with a high full resolution. What are the dose reduction and image quality optimization options for this scanner? Again, the focus field of view is optimal for full heart coverage in one heartbeat. 120 millisecond effective temporal resolution gives us basically motion-free coronary arteries. I will show you a couple examples later. There's a new deep learning noise reduction algorithm, which is an AI-based technology to reduce image noise. There's a model-based adaptive filter in the system, which is an advanced directional noise reduction method, and also an integrated iterative reconstruction technology comes with the scanner as well. Prospective ECG triggering mode is used to minimize X-ray exposure for the patients, and 0.5 millimeter slice thickness with a 0.25 millimeter increment creates up to 560 images per rotation. So let me show you a couple examples. First, this is a 72-year-old male patient who arrived for CAD rule-out. We tried beta blockers, but hypotension was detected, and we could not give further more beta blockers. So the scanning heart rate was 75 beats per minute, and with the previous scanners, usually on the RCA, it gives you motion artifacts, but not in this case. You can appreciate a large dominant right coronary artery with basically total motion-free images. Our next case is a 60-year-old male patient who arrived for CAD rule-out, and he had a trigeminal rhythm, which is kind of like a nightmare for coronary scanning because you don't really know what to expect in these cases. But actually, the heart rate ranged from between 45 and 106 beats per minute. But again, we were able to image the coronaries basically without motion and with a reasonable effective dose. The next patient is a 62-year-old female patient who came for thoracic stent graft control. You can see the larger field of view and the aneurysm in the descending aorta. You can also appreciate a small endoleak in the aneurysm. And the last patient is a 79-year-old male patient who came for TAVI planning. And the TAVI planning on this scanner looks like an ECG-gated heart and with the same contrast bolus, a non-gated full aortic step and shoot scan to cover the whole aorta to assess the access routes. So in summary, Spotlight is the first dedicated cardiovascular and thoracic scanner on the market. Its robust design provides comprehensive clinical information for diagnosis and therapy planning. The one-beat whole heart coverage really makes a difference, and the fast rotation time allows us to scan even the most challenging cases with good image quality. And also with the added wide field of view options, full thoracic imaging and vascular scanning possibilities are enabled now. Thank you very much for your attention.
Thank you very much. For the sake of time, we'll move on with the presentation, and we'll have time for questions at the end. And it's wonderful to see how far Arinat has progressed. Just a note of in history. Then I just would like to pay tribute to Dr. Udi Daphne, who was the founder and the first CEO of Arineta. I'm not sure if you know, but he was the one that invented the concept of multi-slice CT 32 years ago. It was single-slice CT and then multi-slice CT. So 32 years ago, and since then we have multi-slice CT. So welcome now to the next speaker, which is Keith Shannon from Caristo. Good morning.
Thank you very much, Chairman, ladies and gentlemen. It's a pleasure to update you on Carry Heart technology for comprehensive assessment of coronary plaque and inflammation. We've all been brought up as clinical cardiologists and as imagers with a focus on coronary plaque as the embodiment of coronary artery disease. And of course, that's crucial for patient management, particularly symptoms and revascularization. But there is increasing understanding that our historical focus on plaque gives us an incomplete picture of disease activity and risk. And this recent study, bringing together more than 30 different studies and 30,000 patients with the editorial in JACC Cardiovascular Imaging, indicates that there is more to coronary artery disease than the embodiment that we see in plaque alone. And this was demonstrated recently by looking at a large data set gathered from 8 NHS hospitals in the UK as part of the Orphan study led by the Oxford group, presented at the AHA late last year, which in 40,000 scans, these were scans done for clinical reasons and followed up for up to 10 years, you can see that patients who had obstructive coronary artery disease on the index scan did indeed have a higher rate of both cardiac mortality and MACE over the follow-up period, as would be expected and as demonstrated in other large cohort studies. However, the patients who did not have obstructive disease did not have a benign outcome. There was still a relatively high event rate in the patients who had no obstructive disease. So this is, of course, compounded by the fact that the overwhelming majority of patients referred for clinically driven CT coronary angiography do not have obstructive coronary artery disease. Only about a fifth have obstructive disease. So although the rate of cardiac mortality and the rate of MACE is 1.5 to 2-fold higher in those patients, the aggregate result is that more cardiac events and deaths occur in the group of patients referred for CT coronary angiography who do not have obstructive disease. And this is a real challenge for us as we diagnose and manage our patients. And of course, we see that day in, day out with our patients and our scans. Here are 2 fairly similar looking patients, middle-aged men, with chest pain, the usual range of risk factors. Their coronary CT angiograms show the sort of patterns of disease that we routinely see. Both patients were treated with routine medical therapy, but their outcomes were very different. And the missing piece, if you like, is the fact that coronary inflammation was invisible on a routine CT coronary angiogram, but the patient on the left had no cardiac events over an 11-year follow-up, whereas the patient on the right, in fact, had a fatal outcome. And when those scans were subsequently analyzed retrospectively using the Carry Heart technology to evaluate coronary inflammation by the analysis of perivascular adipose tissue attenuation index, or PHI, you see a very different picture. And of course, we now know that inflammation in the coronary artery wall is a fundamental aspect of coronary artery disease pathophysiology. It's the driver of plaque progression, and it's also the initiator of plaque events that lead to both mortality or MACE. We've seen that in multiple phase 3 pivotal trials, which show proof of concept that targeting inflammation is a valid therapeutic option that improves outcomes. And we now, of course, have clinical guidelines recommending that anti-inflammatory drugs can be considered in patients at high risk. The challenge is identifying who those patients are in order to target our therapies more accurately. This topic has been prominent recently, and you can see that many of you will have seen in this month's circulation cardiovascular imaging studies showing that the assessment of coronary inflammation adds important additional information to the assessment of plaque. And there's a nice editorial from Dr. Ferencik that I'm sure you'll have read as well, showing that non-invasive imaging of coronary artery inflammation carries a major potential for improving diagnostic and prognostic manifestation of our patient. And this is where the CariHeart technology comes in, which is able to characterize and quantify coronary plaque, inflammation, and risk all in one application. And CariHeart generates the following report, and that has three important aspects to it. First of all, for each of the three main coronary arteries, CariHeart calculates the Phi score, the Fat Attenuation Index score, which is an individualized quantification of coronary inflammation in each of the three main coronary arteries, adjusted for age and gender. So each artery for each patient receives a score on a percentile value, and this is a measure of disease activity. It's not a measure of disease structure or obstruction, it's the fundamental activity. It also generates a comprehensive assessment of coronary plaque with all of the usual detailed parameters of plaque volume, distribution, plaque composition, etc. And it puts all of this information together for the individual patient into the CariHeart risk. The absolute risk, it calculates from those aspects that I've mentioned, the individualized risk of a fatal cardiovascular event within the next 8 to 10 years. So it's a comprehensive assessment of that patient's disease and, importantly, their risk, based not just on structural aspects, but on the coronary inflammation. And as I've already shown you, that's a major important driver. CariHeart is delivered via a cloud-based portal. It can analyze any scan from any manufacturer's platform. It's been calibrated for all of those, and it's already cleared for clinical use in many parts of the world, including the UK and EU. Finally, I just want to show you some exciting recent data presented in the AHA late-breaking science session last November related to the Orphan study. And this shows that when we take that cohort of patients that I mentioned before, and I showed you how obstructive disease predicts a moderate increase in risk, we've now been able to analyze about 4,000 of those CT scans using the CariHeart application to quantify coronary artery inflammation. And so these Kaplan-Meier curves show the outcome for patients stratified by quartiles of their Phi score. Phi score is the quantification of coronary inflammation. In these graphs, I've shown you the Phi score for their LAD, but the graphs look almost identical if you use the right coronary artery or the left circumflex. And on the left, you see cardiac mortality over follow-up up to 10 years. The median follow-up was about 4 years. And on the right, you see MACE, and the pattern is very similar. And what's very striking is that on top of anatomic distribution of disease, clinical risk factors, age and sex, those have all been corrected for in these Kaplan-Meier curves. You can see that the quantification of coronary artery inflammation is a major driver of mortality and MACE outcomes, such that if you are in the top quartile, the top 25% of people with inflammation scores in their LAD that are high, you have a 20-fold hazard ratio of death in the 10 years following your index scan, and about a 7-fold for MACE. Now, of course, this is in all patients referred for clinically driven CT scan. And so the Oxford group next looked at the patients who have no coronary artery disease. They have no plaque, no calcium. In other words, their CAD-RAD's 0. And I think this is the most sobering result. that if you again stratify them by their LAD Phi score, so this is the quantification of coronary inflammation in patients who have no plaque and no calcium, and incidentally we found that that was about 32% of this population of patients. Patients in the highest quartile, the 25% of patients in the highest quartile of LAD Phi score, even though they have no plaque or calcium, have got a risk of mortality or MACE in the following 10 years, which is comparable to patients who have advanced disease. So this is a very important new insight into the importance of coronary inflammation as an additional predictor of risk. So just briefly to show that CarryHeart, the technology, Caristo's technology, is already being implemented in the National Health Service in the UK. We did a real-world survey to ask how this technology might change clinical management in 4 hospitals in about 800 patients. And the summary here is that about 55% of patients, about half of patients, when CarryHeart was implemented retrospectively on their CT scans, did not have a change in clinical management, but that there was a clinical management change in about 45% of patients when the scans were subsequently reanalyzed using the CarryHeart technology. So this indicates that the implementation of CarryHeart on top of routine clinical CT interpretation has the potential to change management in a substantial number of patients. And that is now being implemented in a larger study in 5 NHS hospitals shown here to look how a risk-based evaluation, rather than only a plaque-based characterization, can change the way that we stratify and treat our patients, to look at how this improves outcomes and indeed reduces costs. We're working closely with many private clinicals and hospitals in the UK, and we're very excited to have just undertaken a new partnership with the pharmaceutical company who has the marketing for Colchicine, to look at how targeting patients with high inflammation may be able to help direct and stratify patients for the use of anti-inflammatory drugs. So in summary, in patients undergoing CT coronary angiography, it's sobering to note that the aggregate majority of events occur in those patients who do not have obstructive disease on their index scan. Measuring coronary inflammation using the CarryHeart application is able to strongly predict both fatal and non-fatal events independently and in addition to clinical risk factors and plaque. And this has the potential to make major changes in clinical management. Therefore, Caristo's CarryHeart technology to quantify inflammation, plaque, and risk assessment has the potential to really change the way we understand coronary artery disease and manage our patients. Thank you.
Thank you very much. I kindly would like to remind the speakers to keep to 10 minutes, otherwise we will not have any option at the end for questions, which I think would be really nice to have that time for question and answers. So without further ado, I would like to introduce Professor Pontone, who will talk about heart flow with clinical evidence review. Thank you.
Good morning again. I will discuss about the evidence, scientific evidence of the use of FFR-CT in clinical practice. The first question is why we need the FFR-CT, because we have a lot of different options to detect ischemia. We have the standard XM, stress MR, SPECT, whatever you want, but we need to understand better one concept. The DANICAD-1 and DANICAD-2 study has showed how when we apply the standard stress test in the setting of a patient with proved obstructive coronary artery disease, the sensitivity of this test, SPECT, stress MR, or PET as well, is not enough robust. So there is now a trend to develop a new tool to detect ischemia in the gate of computed tomography, and FFR-CT is one of these options. Is accurate and cost effectiveness? Yes, we have a huge amount of data on that. Regarding to the accuracy, the most famous paper and study is the NXT trial, who showed how when we add FFR-CT on top of CTA, the accuracy is increased from 53% up to 81%. And in terms of cost effectiveness, the first evidence was showed in the platform trial 10 years ago, in which we used FFR-CT as gatekeeper to invasive coronary angiography in patients with indication for cath lab. And when you use the FFR-CT as gatekeeper, basically we have canceled 61% of the planned invasive coronary angiography, and among those patients addressed to the cath lab, only 12% had no obstructive coronary artery disease. So the result is that we cut a lot of invasive coronary angiography, and the diagnostic yield of this gatekeeper is extremely robust in order to address the properly patient to the invasive coronary angiography. The result is that we reduce the overall cost about of 23% in terms of global management of a patient with ischemic heart disease. Of course, these are not randomized trials, so there was the need to have data from a randomized trial, and the randomized trial is the PRECISE that was just published with the first 2 papers this year on JAMA Cardiology. In the PRECISE trial, what we did? In the PRECISE trial, we randomized the population in 2 different arms. The standard of care, I mean any kind of stress test, and the PRECISE pathway. The PRECISE pathway was based, first of all, on the use of the PROMISE risk stratification. If this risk score was suggested the presence of a low-risk patient, no further tests are required. If it was different than low risk, we perform CT and FFR-CT, and then we decide what to do on this patient. These are the composite primary endpoint, MACE and invasive coronary angiography without obstructive coronary artery disease. What we observed basically, that the PRECISE pathway was able to reach the primary endpoint. We have a reduction of the primary endpoint of 70%, mainly driven from the prevalence of obstructive coronary artery disease in the cath lab during the invasive coronary angiography. And these are basically the clinical impact. We had a fewer number of false positive cases for a factor 4, and we have an improvement of diagnostic yield during the cath lab. One of the interesting impact of that is not only that we avoid invasive coronary angiography because we don't find pathological FFR or something else, but thanks to the capability to detect subclinical atherosclerosis, even in case of FFR-CT is negative, we have a huge result in terms of increase the use of lipid-lowering agent, more than 20%, and increase the use of antiplatelet agent use. This was already observed in the SCOT-ART, for example. That was the explanation why in the SCOT-ART the use of CT was associated with a reduction of a myocardial infarction in the long-term follow-up. But of course there is a competitor. The competitor is the stress CT perfusion, and now we can integrate the FFR-CT with the stress CT perfusion. Stress CT perfusion is very robust as well. As you know, there is a similar diagnostic performance as compared to the FFR-CT, red line and green line, but of course we can imagine it to have a sort of sequential strategy. When you have a patient with suspected coronary artery disease, the first is to rule out stenosis and atherosclerosis, and CT. This is the job of CT. If you find atherosclerotic disease, then you can calculate on top of CTA the FFR-CT. If this is normal, more than 0.8, you can stop. If it is clearly pathologic, so I mean lower than 0.7, of course there is enough evidence to address the patient with invasive coronary angiography. But sometimes we have a gray zone in which FFR-CT is between 0.75, 0.76. In this setting, the perfusion can provide additional information just to decide if the patient merits or not invasive coronary angiography. And this kind of sequential strategy is the best compromise in terms of evaluability, in terms of rate of reclassification, in terms of rate of agreement with the target vessel to be revascularized, also in terms of radiation exposure. In other words, FFR-CT as gatekeeper of cath lab, or sometimes as gatekeeper of CTP in case the numbers are equivocal. This is just an example of a patient with disease at the coronary artery imaging. There is a border zone value of the FFR-CT 0.76. We add the perfusion, static perfusion on top. That was negative. The patient performed invasive coronary angiography for protocol reason, and the invasive FFR rule out the presence of ischemia and functional significant coronary artery disease. But FFR-CT is not only diagnosis, it's also prognostic stratification, and as you know, there is a very large registry with more than 5,000 patients, the ADVANCE trial, in which it was observed how the outcome is excellent if you have a normal FFR-CT. The outcome at 3 months, read the line, or also the outcome at 1 year. What is interesting is that FFR-CT is usually calculated in patients with atherosclerotic burden. And this means that when you have atherosclerotic burden plus FFR-CT negative, the outcome is excellent. And this means that in other words, this number is able also to summarize the conceptual risk related to the atherosclerotic burden. And this is extremely important information. But which are the mechanisms that are behind the prognostic value of the FFR-CT? We learned this concept from the EMERALD-1 trial, in which, as you know, this was a case control study comparing patients who experienced the acute coronary syndrome versus patients who has no acute coronary syndrome, in which there was a CT available a couple of years before the event. And the CT were analyzed. And as you can see here, one of the predictors of the culprit lesion was the delta FFR-CT across the lesion and also the wall shear stress across the wall of the vessel. And this was probably the explanation why the FFR-CT is able to predict this kind of event. Just a couple of examples. These are 2 patients with no obstructive coronary artery disease in both of cases, but in the first one, we have adverse plaque characteristics, and we have also adverse hemodynamic characteristics according to the FFR-CT analysis. Indeed, in that lesion, the patient experienced acute coronary syndrome. In this case, we have non-obstructive coronary artery disease, no hemodynamic adverse characteristics, and there was just a mild progression of disease. Of course, the problem of this kind of analysis is the time consuming to do the analysis. And therefore, for this reason, now in the experience of the EMERALD-2, an AI solution as well was added on top in order to understand if the AI quantification of the adverse hemodynamic characteristics is able to improve the prediction of event on top of CAD-RADS and on top of qualitative definition of iris plaque. And as you can see here, it is able to do because the area under the curve increased from 0.76 to 0.86, and this is the validation court. Last topic in the last minute of my presentation, to use all this information to guide revascularization. At the moment, there are 2 big trials on that. The first one is still an ongoing trial. There will be a lecture of Professor Collet later today. This is the P4 trial. In the P4 trial, what we are doing? We are enrolling patients with indication for the cath lab, so stenosis higher than 70% in pathologic FFR, and then these patients are randomized to the standard of care, that is PCI IVUS guided, and CT and PCI CT guided. What means CT PCI guided? Means 3 concepts, basically. First of all, to identify the presence of lesion. Second, to identify the length of the lesion and the best projection for the deployment of a stent. And last but not least, to identify very well the landing zone for the treatment. At the moment, we have enrolled a bit less than 400 patients, and then we are still going on with the enrollment. What is interesting that you can use the FFR-CT planner to plan in advance a different strategy in terms of revascularization and to calculate the expected FFR according to the strategy that you have used. Last but not least, and I close my presentation, is the use of FFR-CT to guide the surgical revascularization, the CABG. And this was done in the fast-track trial. The trial is just finished in terms of enrollment. Professor Serrais showed some preliminary data yesterday, and the paper is under review. I want just to show you this concept. This is a slide provided by Professor Serrais, in which you can simulate the surgery, exactly where to put the graft and when, which kind of protection you can guarantee. Any impact on the real world? Yes, the fish and chips trial showed how the extensive use in the real world of the FFR-CT is able to have a clinical impact, and these are the outcomes reached during this paper. What will happen in the future with the photon counting, we still not know exactly, because if we change the visualization, we change also what we calculate on this data set. This is a world that we have still to discover. And again, let me invite you for the next ICNIC trial in May. Thank you.
Thank you very much, Gianluca. It was wonderful, and it's a pleasure to continue our technology parade with our industry partners, and it's an honor to introduce again Rolf Rajmakar, who's going to talk to us about Spectral CT.
Thank you very much. I don't see my... Oh, there we go. Good morning. Well, adding new dimensions to the cardiovascular domain. So let's have a look at that. Let's set aside the challenges of freezing coronary motion. If you are, as cardiac imagers, successful in that, you're still facing a lot of challenges, like blooming of high-density objects, like calcified plaques and stents, beam hardening artifacts, and they especially hindering when you're looking at a potential perfusion deficit. Patients with poor kidney function, iodine load in TAVI patients, suboptimal contrast timing, non-calcified plaque composition. We heard a lot about that. We know there is a significant overlap, Hounsfield-wise, between fat and fibrotic tissue. Left atrial appendage, right? Pre-AP. Am I looking at slow flow or am I looking at clot? And myocardial imaging, detection of late iodine enhancement. And these can all be very challenging on top of even when you have a perfectly motion-free coronary artery. So all these issues, these challenges are linked to the single energy nature of conventional CT today. And you don't necessarily solve these issues, or mitigate these issues, by going to a wide area detector or a very super fast scan mode or whatsoever. No, there is a different way of doing that. And the solution is spectral detector CT. Every photon counts. So instead of looking at only conventional CT images, single energy, we maximize the value of each and every photon by providing novel maps coming from 2 energy levels. And this is called detector-based dual energy CT. And in Philips, detector-based dual energy CT, it comes without a single penalty. So we don't penalize radiation dose, we don't see a degradation in temporal resolution. Everything remains unchanged. So this is a no-brainer to use. This is unique to Philips. Now, this is our device, the Spectral CT 7500. You can look at the specs. I don't think those are that much relevant. One thing I would like to highlight is the introduction of a novel tool, AI, and that's what we use to salvage segments which are still blurred due to motion, due to, let's say, insufficient temporal resolution. And in this case, as you can see, the proximal, or let's say the mid-RCA, we see significant motion artifacts, non-diagnostic, but then by using a novel AI tool, it's called Precise Cardiac, we can really salvage that segment. So that is great, and that really helps, and very nice. We got this quantified and published by the study of the Utrecht University group, and it showed that we see an 11 times reduction in motion artifacts. So the proof is there. But let's go clinical. What can we do with spectral? Why are we focusing that much on spectral? Well, we all know blooming of calcified plaques, and here you can see the calcified plaques in the Prox LED, right? And that might, especially not any expert readers, but let's say the people who are not that expert yet in coronary imaging, they might overcall this, and they might call this a significant lesion, and the patient is sent to cath. Well, if you start using virtual monoenergetic imaging, and you go to, for example, to 150 cath, we see a significant reduction of calcium blooming, which allows for a more robust lumen assessment. Also here, look, in the cross-sectional, you see, there you might overcall that. If you go to high mono E, you can see that there's a significant reduction of calcium blooming. Nice. Let's look at plaque. So here we see a mixed plaque in Prox LED, and then if we look at cross-sectional, we see this. And then we see some non-calcified plaque, and then there is this dark sign. Is this the Palmaurovitz napkin ring sign? Yeah, it's very difficult and challenging. But when we add spectral, and spectral is always available at your fingertips, you don't have to do anything else. What we do is we can extract spectral curves by plotting ROIs, and then we can extract curves and look at the ratio, for example, what happens in Hounsfield units at low mono E and high mono E. And this really helps you to distinguish and differentiate fat versus fibrotic tissue. So this, for sure, will help plaque assessment tools. Iodine reduction. We know in TAVI patients, you cannot always give that amount of iodine that you want. So now, on a routine basis, Professor Douek in Hôpital Cardio in Lyon is injecting 20 cc's of contrast at 2 cc per second. And then on conventional CT, you see this is a watercolor painting, right? And the hound field unit is only 140. So this is not really of diagnostic quality. But then it's the same scan, but you easily change the image into 40 keV. And when you go to 40 keV, look at the hound field unit. It's now 340. So this allows you, low mono E, to prospectively reduce significant amount of iodine to your patients. Published in JCCT. Artifacts. We deal with artifacts. This patient was sent to CT, and we see pacemaker wires here. And when they move, the artifacts become really, really horrible. And then this might hinder the image quality of the proximal segment of RCA. Well, if we look at iodine on water in a robust fashion, we see significant reduction of these artifacts. So now you have a clear view on the mid-RCA. This patient had significant disease in LAD, as you can see here. And then, you have to look, as a cardiac imager, you need to look at coronaries, but you need to look at also the other stuff. So you look at the myocardium, and we know there is significant disease in coronary, but then you look at this. Is there a first-pass perfusion deficit? Well, I don't know. It's probably beam hardening. I see a high-density column of contrast in the LV. So then you have a question mark, and then you don't know. Well, with Spectral, you can make a confident call, yes, there is a significant first-pass perfusion deficit. See that here in the low mono E? Look at the quality, look at the signal to noise, and look at iodine. This is an iodine image. And then we can even quantify iodine. So 1.5 milligram in the affected area versus 2.8 milligram per milliliter in the healthy free wall. So now, not only qualitatively, but also quantitatively, we can identify perfusion deficits. This patient had a clot, or clot slow flow in left atrial appendage. Conventional hound field, you don't know. But with iodine, you look at iodine, you drop an ROI, you measure 0.17 milligram per milliliter, this is clot. This is a 3-second exercise. Stents. Well, this is not the best kernel, and this is not the spatial resolution of a photon counting scanner. We realize that. So this is doubt. What's going on here? And there might be some blur due to motion. What am I looking at? I don't know. Well, don't worry. Just change the image to iodine or water. Here you go. And significant instant restenosis. Confirmed by cath. Patient, since 36 hours suffered from chest pain. The patient was sent to the CT, and we saw an occluded RCA. And then we did late iodine enhancement. And here you see the late iodine enhancement of the first pass. You see here the deficit, but then you do a late iodine enhancement of 7 minutes later. And here you see microvascular obstruction. With CT, is it possible? Yes, it's possible. With Spectral, it becomes feasible to do. See, in cross-section, short axis, look at the quality of a virtual mono E, 40 keV. Even a junior radiologist or cardiac imager will be able to identify this MVO. Myocarditis, patient comes in with chest pain, slightly elevated troponins, and then, you do a CT, but the coronaries are normal. And then, you can wait and send the patient to an MR. Well, not every institute has access to an MR the same day. You might have to wait 3 weeks, 4 weeks. You just do Spectral. And with Spectral, you do a late iodine enhancement scan, and again, look at the quality. Subepicardial, spotty, hyperdense lesions. Now you are confident. One-stop shop. It becomes feasible with Spectral CT. I'm almost there. This patient suffered from a chronic total occlusion in the circumflex, and then we're talking about viability imaging. So you do a 7-minute late scan, noisy in conventional CT, but then we go to low mono E, again, very easy, very robust to detect, and again you can quantify. And when we have iodine information from a late phase, it's just a few clicks away from extracellular volume. So then we load this delayed scan, iodine density images, into our application packages, and then within 30 seconds, we can provide you with extracellular volume. So, Spectral CT, to conclude, low mono E is there to boost iodine and reduce iodine load, and it really helps you to identify myocardial deficits. perfusion deficits. High mono E to reduce calcium blooming and to solve beam hardening. IDA maps allow qualitative and quantitative perfusion deficits. IDA no water helps to reduce streak artifacts. Great potential for spectral data with respect to plaque characterization. Clot versus slow flow, easy. And late IDA enhancement made easy with spectral. So the one-stop shop is really, really there. Well, I realized this was a bullet train. If you're interested, please scan the QR code in the left upper part of your screen, and then you leave your email address, and I will do an online demo for you. Okay? Spectral CT 7500, it's bringing the right tools at the right price to mainstream cardiac imaging. Not every site has the budget to buy these super premium scanners. And 80% of the work of coronary imaging is done in the mainstream hospital. So we need to provide those cardiac images with the tools they need at an affordable price. Spectral CT 7500. Thank you very much.
Thank you very much. Very interesting. We go to the last presentation in this session, and Dr. Thomas Almendinger is replaced by his colleague Vishal Karpatri. Welcome. And this is a presentation by Siemens Healthineers on innovations in cardiac CT. The floor is yours.
Just a single comment. There is still an opportunity to submit questions through the app, so feel free to write your question if you wish. Thank you.
Sure. All right, thank you very much. So yeah, unfortunately, Thomas couldn't be here, so I'm taking over. And we're talking about spectral resolution and beyond, the innovations within cardiac CT. Quick disclaimer, I'm a Siemens Healthineers employee, and Thomas has promised me there are no formulas, so we will keep the physics to limited as much as possible and try to show you some cool new stuff that we've been working on and we're also likely to share with you. Very, very briefly, of course, cardiac imaging is challenging, right? We all know this, we all kind of witness this in our daily lives, and it's because, again, we're dealing with motion, so this is where the temporal resolution comes in, right? And this is why we have dual source to tackle that. High resolution, just spatial resolution is also important because you're looking at very small structures, right? So this is the other topic. And then, essentially, we're thinking about, this is a question of different materials, right? Because you have iodine, you have calcium, you have fat. These are the different kind of materials that you're looking within the coronaries. And this is why there's a desire to have spectral imaging available to be able to look at these different materials and decompose them in one or the other way. At the same time, we want to keep the dose as low as possible, right? So this all kind of culminated into a CT scanner that we launched about 3 years ago now. The first photon counting CT scanner, Neotom Alpha. It is a dual source photon counting CT scanner. So essentially, we took everything that we had and put it into one scanner. And this has been out there, and of course, there's a lot of benefits that photon counting CT brings. I'm not going to go into so much details, but these are the, let's say, the big 4 main benefits that you can imagine. Smaller pixel detectors, meaning higher resolution, elimination of electronic noise, intrinsic spectral sensitivity, so the spectral is built into the scans because it's done at the detector level, and you have equal energy contributions of different photons, also the little ones and so on. So there you have that. I will focus mostly today on the higher resolution aspect of it, and a little bit on the, go back a little bit, and a little bit also on the spectral side of things, yeah. So very, very briefly, I'm not going to get into the details of this, but if you're curious, happy to explain it to you later on as well at the booth. But essentially, the detectors are different from a conventional CT scanner because we're not dealing with light anymore. We deal with electrical impulses and photons directly. So we don't need the septa, which means we can make the pixels smaller and we can actually increase the resolution without giving dose penalty. So just to give you a comparison to somatum force, we're actually looking at 3 times more channels per row. When we're looking at collecting information, and all over around totally we're increasing it by like 5 to 6 times. So there's a lot of information, a lot of data coming in. What does that translate to clinically? Clinically means you can get scans with 0.2 millimeter slice thicknesses, and the in-plane resolution comes to around 0.11 millimeter as well. Again, this is a paper from Zurich, I believe, where it also illustrates that actually because of the higher resolution, you're actually also able to push the kernels much higher than you were able to do in the past. And within the paper also illustrates what could be the optimal kernel to use in such a high resolution case. The other aspect I would like to also highlight is the dual source aspect of it. When we push the resolution so high, actually the effects of motion are pronounced even more. So here we have an example performed with this neotome alpha in the normal mode that we have. We have 66 milliseconds, temporal resolution, high resolution. However, we try to throw away just one of the information from one of the tubes and one of the detectors to kind of use it in a single mode, and then we realize actually you start getting motion. So the point about high resolution and temporal starts becoming even more and more important when you are dealing with these kind of higher resolution cases. And again, there's a paper out there, also from Zurich, looking into the importance of temporal resolution for ultra-high resolution coronary angiographies. And then we had another paper coming from Freiburg, which looked at the high-risk patient group. So this paper, I think it's been shown multiple times throughout the talks also yesterday. Not spending too much time on that, but it's just that even in high-risk patients, there is the benefit of using high resolution. So what we call the quantum HD cardiac mode, the ultra-high resolution really brings benefits also for these. However, we had a small limitation. If you chose the ultra-high resolution mode, you couldn't get the spectral information as well because of just the data that was coming out of the scanner. And in the words of Dr. Williams and Dr. Newby, but ultra-high resolution and multi-energy imaging may provide the revolution. Yeah? So we thought, let's initiate that and let's enable that revolution with the first step. So from now on, with the new software update, we will actually also let you have spectral information in addition to having the ultra-high resolution scans as you will for the same patient with the same scan. So for example, on the left, the quantum HD cardiac is the ultra-high resolution. Within the same thing, it's been reconstructed at 0.4 millimeter slice thicknesses, but that is then full spectral. You can use monoenergetic images. And then on the right, on the very left side actually, you see the spectral pure lumen, which is our application of using spectral information to be able to identify just the calcium and turn just the calcium off to be able to get rid of the blooming effects. So again, this was a lower heart rate, of course. Here's a higher heart rate, again, showing you the benefits of dual source technology, again, in the 73 beats per minute patient. Moving further, we also mentioned and we also realized, of course, that not every site can have a photon counting CT scanner. And of course, this is where we also try to introduce Somatome Propulse, which is our latest generation of dual source CT scanners, which also is more useful for secondary or tertiary or rural areas which might want to get started with cardiac imaging and have that high quality cardiac imaging available to them more readily. However, of course, we've also realized that, scanning the heart is not easy. Again, there are different ways of doing it. However, the ranges can vary. So essentially, you always need to think about how can you kind of have the optimal imaging regardless of whatever size the detector you might have, because there's various ones out there. Increasing the detector width might help with these kind of situations like step artifacts. So this is something that we've been kind of plagued with a little bit. And again, like I said, increasing detector width could help. However, it comes with its own limitations, its own physics problems, heel-toe effect, cone beam artifacts, X-ray scatters, and so on, so on. So, and a lot of these step artifacts are more cosmetic rather than a real, let's say, diagnostic challenge particularly. However, we still wanted to solve this issue. So this is what, in theory, what we want is a really clear image of the coronaries and the heart. But the acquisition doesn't always look that way because there's motion in various directions. Maybe the patient moves, maybe the patient breathes, yeah? Or from the adjacent cardiac cycle. And then the standard approach that we had was essentially putting it together, and then that led to sometimes blurring around the edges of where the stacks were. The solution was to use something called true stack, which would essentially put the slabs on top of each other and the anatomies would be repeated in the 10% part. However, we have now, with the new feature Z-Free, essentially optimized it to essentially be what you wanted it to be. And we've done this by maintaining the local structure and the morphology, so when you measure stuff and so on, that no new artifacts are being introduced, and again, it's a non-registration process that works on this one. one more thing is that it's actually very built into the imaging chain at quite early on. So it's not something that is done on a post-processing workstation. It's actually done with the raw data on the console early enough within the imaging chain that all the iterative reconstructions and everything else is done on top of that. So this is how it is enabled today. And here's some more clinical examples for you to enjoy. Essentially, again, we're rolling out not only to the Sumitomo Propulse, but also to the Neotome Alpha, and essentially most of our single-source CT scanners as well will be getting this feature. Here's another example of some of the coronaries, the LED, where again, showing you the TrueStack on one side and Z-Free on the other. Here's another one to just show you that it works not just in the coronaries, but for the whole structure of the heart as well. And again, these would, I believe, improve some quality of life for radiologists out there who might have in the past struggled with this situation. So that's more or less it from my side. Thank you very much. And yeah, if you have any questions, feel free.
Thank you very much. I think we still have a few minutes for questions. If I may ask all the speakers to come to the podium, we'll stand over there. There's 5 chairs here, and we're open for questions.
Thank you very much. Are there any questions from the audience? Let's see one. Yeah. Please introduce you with your name and ask the question.
Karl Michalski from Poland. Congratulations. My question is related to CARIST demonstration. Impressive data on increased mortality. What is the mechanism of increased mortality in patients with SCCT0? It is a missed plaque or plaque progression? Do you have data on this?
So these are, the answer is we don't know because we don't have post-mortem and we don't have clinical event, adjudication other than death. But these are coronary sudden deaths. These are presumably plaque events related to invisible plaque that during the period of follow-up, which of course was up to 10 years. So we're not saying that on the index CT scan there was plaque that was missed. We're saying that there was high inflammation quantified by Caristo's CariHeart technology, which presumably drove plaque progression, and not just plaque progression, but high-risk plaque progression over the subsequent follow-up period. And that resulted in a significantly high rate of either death or MACE events over that 10-year period.
So you have data that there was acute event and this
yes.
mortality is mostly cardiac related, yes?
Yes.
Okay, thank you.
And perhaps I should have emphasized that this technology can be applied historically to scans that were done on 64 slice and higher going back many years. And that's very powerful because you get 10-year follow-up by being able to go back to scans that were done 10 years ago, which means the clinical data that are then able to be linked to those scans is extremely powerful. So 40,000 scans followed for up to 10 years.
Okay, great. Thank you.
Just a technical question, which is maybe in relation to the previous question. Is the system sensitive to the tube current and tube output? Because when you change tube current and tube output, plaques sometimes look different.
So those data are all part of the CariHeart application. All of those technical details are included in the file, which is uploaded on the web-based portal, on the cloud-based portal. And the technology has been validated across multiple vendors, multiple tube voltages in various studies, where even to the point that patients have undergone multiple scans on multiple different scanners in different locations in order to create this application. So generating the clinically applicable CariHeart product, which is now CE marked, has been an enormous amount of work rather than using crude PCAT values. If you take the attenuation of the perivascular adipose tissue, that already gives you a good indication of inflammation. But to make a clinically applicable tool that Caristo Diagnostics has done requires an enormous amount of technical development, which is now embodied in the CariHeart product.
Perfect. Gianluca, maybe a question for you, and might be a little bit provocative. We see the CT-FFR in the American guidelines. What do you think will be the next European guidelines?
Of course, have you seen the American guidelines have introduced the FFR-CT just because they arrived a couple of years later at the European guidelines. I am not in the position to be sure what will happen in the next step of the European Society of Cardiology guidelines, so I have no answer for that.
But if you have it for free in your disposal, so like, for example, you can apply to any coronary CT that you do. Would you use it routinely?
In my hospital, you mean? Yes. We use, of course, one of the barriers is the economical barrier, as you know, because in Italy and a lot of countries there is no specific reimbursement for that, and therefore this is one of the limitations. But when there is no economical barrier, there is a formal indication, is the usual step after CTA when we want to detect ischemia. Of course, if there is economical barrier, we have to follow different solutions.
Thank you, Gianluca. And I think it's great that we now have the first RCT, or not the first actually, a new RCT in heart flow, CT FFR, because for many new biomarkers we really miss the outcomes where management is actually based on the markers that we can now derive from CT. So congratulations on that. I see a question, yes.
I have one question. Is there any studies on measuring FFR-CT during hyperemia after adenosine infusion?
Theoretically is a contradiction because the model was already developed simulating the adenosine vasodilatation, and therefore at the moment from technical point of view doesn't make sense to add true adenosine injection on top. This is the first consideration. Second, the reason why the mathematical model was developed in the past, simulating the dilatation, is that because when you use adenosine, of course, you have an increase of heart rate. And the heart rate is one of the most important determinant of FFR-CT rejection for the analysis because it's very sensitive to the misalignment. So there are no data and probably is not a direction that makes sense from a physiopathological point of view.
Thank you. I have a question for Dr. Germendi about the Arineta CT scanner. Do you also have experience with CT perfusion with that technology?
Yes, thank you. Actually, static perfusion is possible with the scanner. So we performed a couple measurements using this. Unfortunately, dynamic perfusion is not yet possible, but we are trying to work on this. But yeah, it's, the large coverage is absolutely a benefit in this regard.
Wonderful. I think any other question? So again, I would like to thank all of you. It's unbelievable how the technology is moving forward, and it's not just toys. Those are clinically useful tools for all of us. I would like to thank the speakers for the excellent talks and for you. And then next in the program is a coffee break, an abstract poster viewing in the exhibit hall. And at 9:40 in this room, the next session will start, multimodality imaging in chest pain, joint session with SCCT and EACVI. So I thank you all and have a wonderful day. Thank you.